This is a short video concerning the inpatient management of acute and postoperative pain using a multimodal approach. Pain is a complex entity. This slide depicts the multiple components of pain, including perception, modulation, transmission, and transduction, and the drugs used to modulate each step. Multimodal techniques for pain management include the administration of two or more drugs that act by different mechanisms for providing pain control. These drugs may be administered via the same route or by different routes. Multimodal pain management can limit and reduce opioid use. Opioid prescription has become a hot topic because the death rate from prescription opioid overdose has quadrupled in the last 15 years. In 2014 alone, almost 30,000 people died from an opioid-related death, according to federal statistics. The New England Journal of Medicine published an article related to this topic in April of this past year. They stated that 1 out of 550 patients started on opioid therapy died of related causes in about 2.6 years. 1 in 32 will die if given 200 morphine milligram equivalents or higher. The WHO ladder is depicted above, and it illustrates how one should escalate pain medication in a stepwise fashion. Note that whenever an opioid is given, it is always accompanied by an adjuvant and non-opioid medication. Every prescription counts. Multiple studies suggest that perioperative opioid therapy might be associated with increased likelihood of long-term opioid abuse. In one study, patients receiving an opioid prescription within 7 days of surgery were 44% more likely to become long-term opioid users within 1 year compared to those who received no such prescription. Using a multimodal pain approach can reduce postoperative pain, opioid use, and related adverse effects such as nausea, vomiting, constipation, urinary retention, duration of hospital stay, and perioperative care costs, while still providing a high-quality recovery. Anything we can do to decrease the use and duration of these drugs can be helpful to the patient. It is important to note that no more than 1 week's supply of opioids should be written at the time of discharge from the hospital. Plan to wean non-opioids after opioids are stopped or weaned. Randomized controlled trials have shown that multimodal analgesia is associated with superior pain relief and decreased opioid consumption compared with the use of a single medication administered through one technique. The American Society of Anesthesiologists have implemented the following guidelines. Acetaminophen, COX-2 selective NSAIDs, non-selective NSAIDs, and calcium channel 2 antagonists such as gabapentin and pregabalin should be part of a postoperative multimodal pain management regimen. Additionally, unless contraindicated, patients should receive a round-the-clock regimen of NSAIDs, COX-2 selective NSAIDs, or acetaminophen if they are still using opioids. Once the opioids have been stopped, these can be made PRN and weaned as well. The following slides are specific to drug therapies. Acetaminophen is a basic drug that is often underutilized. The dosing is listed on this slide. It is important to note that current guidelines suggest that you do not exceed 3 grams of acetaminophen in 24 hours. It is also important to note that this should be used with caution in patients with hepatic dysfunction. The primary site of action of NSAIDs is believed to be in the periphery, though recent research indicates that central inhibition of COX-2 may also play an important role in modulating nociception. NSAIDs inhibit the synthesis of prostaglandin both in the spinal cord and at the periphery, thus diminishing the hyperanalgesic state after surgical trauma. NSAIDs are useful as the sole analgesic after minor surgical procedures and may have a significant opioid-sparing effect after major surgery. As you know, there are many NSAIDs to choose from, and this slide depicts only a handful available. Both ketorolac and ibuprofen can be administered in IV preparations. IV ketorolac should not be given for longer than 5 days, as it may cause renal impairment. NSAIDs are associated with increased risk of GI bleeding and ulceration, cardiovascular events, and renal dysfunction, and that should be considered when selecting the therapy. Additionally, NSAIDs are contraindicated for management of postoperative pain in patients who undergo coronary artery bypass graft surgery because of the increased risk of cardiovascular events. COX-2 selective inhibitors provide the benefit of blocking only the desired cascade and leaving the beneficial action of COX-1 in place. Celebrex is the only COX-2 inhibitor in the United States. This can be used in postoperative pain control. Used with caution in patients with renal and heart disease. Unlike NSAIDs, Celebrex and acetaminophen do not affect bleeding. The ASA guidelines suggest scheduling dosing of NSAIDs and acetaminophen, and recent clinical studies have shown that improvement in pain scores when taken 3 to 5 days after ambulatory surgery. In addition, acetaminophen and NSAIDs have different mechanisms of action, and research indicates that the combination of the two might be more effective than either drug alone. Meta-analysis of randomized controlled trials report lower pain scores and reduced opioid use when IV opioids are combined with gabapentin and pregabalin when compared with IV opioids alone. For gabapentin, the starting dose in an inpatient regimen is 300 mg QHS, which can be titrated up to 300 mg TID. For elderly patients, you should use 100 mg. This inpatient regimen is more aggressive or starting as an outpatient, which is a much slower escalation. For pregabalin, the starting dose is 50 mg QHS and titrating up to 100 mg TID. The common side effects include dizziness, sedation, weight gain, peripheral edema and ataxia. For contraindications, please adjust the dose if renal insufficiency exists. There's also an increased risk of suicide, thoughts, and behavior. It is important to avoid abrupt withdrawal. Tramadol is a weak mu-opioid receptor agonist. It can be used for acute and postoperative pain. It works as a serotonin norepinephrine reuptake inhibitor. The common side effects include nausea, vomiting, constipation, dizziness, and headaches. Serious reactions include serotonin syndrome, so it's important to use with caution when other serotonergic agents are on board. Additionally, if the patient has a history of seizures, it is contraindicated. The max dose is 400 mg a day, and normal starting dose is 50 to 100 mg Q6 to Q8. This is a summary slide of the dosing of the drugs discussed in this video, which can be employed in a multimodal pain management approach.